Thank you, everybody. And I've been asked to speak about a topic which hides from us at all times, both of these lesions. So, as Jack Houston very pertinently pointed out, you may not have seen it, but it has always seen you about meniscus root tears. Now, as you know, femur and the tibia to protect the cartilage. And what happens when its attachment onto the bone breaks off? It moves out of its anatomical location and bone touches against bone and there's accelerated degeneration. So it's much like somebody sitting on a pillow which is placed on a chair and the pillow moves forward. So the butt directly touches the chair and there is more pressure onto the butt. So there's less tibiofemoral contact area and hence more stresses. The lateral meniscus is a little different because it's not only a load-bearing structure but also helps in stability, and about 70% of the load of the lateral compartment goes through the lateral meniscus. The medial side, 50% is shared by the meniscus and cartilage. The lateral meniscus root is a primary knee stabilizer for internal rotation at higher degrees of flexion, hence should be repaired along with the ACL reconstruction to reduce stresses on the graft. So when the root tears, you have a lot of pressure onto the condyle, onto the cartilage, and you can see the areas in green and blue show the amount of stresses that go in, which is equivalent to a meniscectomy when you have a root tear. What are the radiological signs? You have extrusion. That means the meniscus shifts more medially away from its location. Something called the ghost sign on a sagittal view, where you do not see the posterior horn of the meniscus, and a truncation sign on an axial view. What is excessive extrusion? Extrusion more than 3 millimeters associated with the meniscus tear and articular cartilage degeneration. So what are the techniques we have? There's a suture pull-out technique, which could be single tunnel or two tunnel, or there could be a suture anchor technique. So how do I do it? This is a little animation of the way I do it. So that's what a root tear is. It's important to first debride the footprint adequately well so that you have lovely glistening, bleeding bone surface for the meniscus to heal onto. You use a standard anteromedial portal with which, using a jig, you get various fancy jigs, but an ACL jig works. From the anteromedial tibia, you drill a guide wire, which is cannulated over with a 4.5 millimeter drill bit. Then, using a passport cannula, you take bites using the knee scorpion that's used to shuttle a suture tape in a simple configuration. Then an ethibond loop is delivered through the tibial tunnel onto the passport cannula, which is used to shuttle the four ends of the suture tape onto the anteromedial tibia, which is then tied over a suture disc. So you can see all of them come out there, and then all these four ends are tied over a suture disc that reduces the root onto its location. So this is classically how it goes. This is a standard root tear. The first thing is identify your footprint. Remember, the medial meniscus root footprint is more posterior than you think. So you identify it, you decorticate it. I like using these standard jigs, but you have fancier, low-profile jigs these days that can go right where you want to without scuffing much cartilage. So once you reach there, you drill it and take bites using the scorpion-like device. Some of them pass suture tapes directly, as you can see. One a little more medial, one a little more towards the tear, so that it reduces the tear as you tie it over the suture disc. I like visualizing it arthroscopically when I'm doing this to be sure that my meniscus is back where it's supposed to be. I do an ultrasound intra-op to see whether my extrusion is taken care of. This is a follow-up of an MRI at X interval of about 6 months, and you can see the extrusion has been taken care of quite well. Lateral meniscus tears, pretty much the same thing, but the lateral meniscus root is more anterior than you think it is. So it's very close to where the ACL is. So very important to see where it's reducing. Once it reduces adequately well, you place in your jig at the right point. Again, do the same procedure that's repeated. Pass your suture tapes through it. I like drilling it through an independent tunnel, and you tie it over a suture disc, and it's stable at the end of it. And then you do your ACL reconstruction the way you normally do it, and you can see the root is quite close to the ACL that you have reconstructed. Centralization is done to reduce extrusion. As you can see, it is a new concept. It is still in its conceptual stages. If you believe in it, do it. So classically, it's been shown that you may not be able to reduce extrusion completely. So when you can't, especially in chronic tears, great cartilage, very important to make the meniscus sit over the tibial condyle. So once you've passed your sutures, delivered them through the anteromedial tunnel, you put an all suture anchor just posterior to the MCL. Once you pass this through, you shift portals, look through the other side, deliver one end, take bites to the meniscocapsular junction with it. And once you've done that, you pass the sutures through the meniscus tissue there. So you've got to pass both ends through the meniscocapsular junction because you want that area to sit over the meniscus, because that's the area where maximum stresses of the condyle are. So once you do this, the first thing you do is you tie your knot for it to sit onto the condyle adequately well. And once you've cut this off, then you can go ahead and you can tie the suture tapes onto the anteromedial tibia over a suture disc, and you can see it's been taken care of quite well, and it reduces extrusion to a great extent. So let's talk about ramps. There's a little animation to tell you how the ramp tear affects an ACL tear. So when you have excessive translation, as you can see here, you can see that little orange thing at the back, that's the meniscocapsular junction. So as you're tugging on the tibia anteriorly, excessive anterior translation, the ACL gives way, and eventually there is a separation of the meniscocapsular junction because there are stresses that are happening which are tensile in nature, and it gives way. And in this way, your checker-in for excessive anterior translation and rotational stability goes away. This is how I do it. I use two techniques. Now I use a single portal technique because I find it a lot easier. So a single portal, this is your meniscocapsular separation. I use a standard suture passer that you use in your bank cart repairs. Take a bite through the capsule. Take it forward, take a bite through the meniscus. And then I like using PDS sutures here because this area is waiting to heal. It's very vascular. So you take how many ever bites you want, deliver it through the same cannula, and tie knots in a sliding or multiple half hitches or a mulberry knot, as I call it, which I find the most effective way of doing it, because the knot security of a PDS isn't great, but the great thing is it absorbs itself. And this is how it is done when you're actually doing the operation. Single portal, you just make sure that you debride that area adequately well with a shaver. You can see that it comes more into view. You use your single portal, you take a bite through the meniscus, take a bite through the capsule. Once you've done this, make sure you don't scuff the cartilage. So point it away from the femoral condyle. Make sure that you have adequate length of your PDS suture, which is delivered through the same portal, and then you have multiple half hitches or mulberry knots, which are used to tie it. Your assistant should show you this area very well when you're tying the knots, and then you have a stable ramp repair done at the end of it, which many times you can visualize anteriorly also when you put in your scope. This is the two-portal technique, which makes life a lot more convenient. Dr. Sheetal has a wonderful technique also, which you guys should look up on arthroscopic techniques. This is a classical ramp repair. There's a high posteromedial and a low posteromedial portal. The low posteromedial portal is to take bites, and the high posteromedial is to basically tie knots, and then you've got your repaired ramp lesion at the end of it. Thank you very much.